Welcome to this week's installment of Stat Plus Conversations, a weekly video chat series exclusively for Stat Plus subscribers. Thank you for joining us. I'm Rick Burke, the co-founder and executive editor here at Stat. And in just a few minutes, I'll be joined by Stat's Los Angeles correspondent, Usha Lee McFarling. But first, a few quick housekeeping notes. At the bottom of your screen, you should see a few icons. Use the chat feature to chat among yourselves or send a message directly to the Stat team. Please note that we will not be taking questions directly from the chat. If you do have a question that you'd like to ask, please use the Q&A feature to type your question over to us, and we'll try to answer it live. There, you'll also be able to see the questions that other attendees have asked and upvote the questions you'd most like to have answered. We will be taking your questions throughout our conversation, so start asking them right away. No need to hold off until the end of the chat. Before we get started, you may have noticed that Stat Plus Conversations are being sponsored by PRA Health Sciences from January through March. With that, I'd like to first welcome Brandon Early, Vice President for Project Delivery, PRA Health Sciences, for a brief introduction. Hi, Brandon.
Hey, Rick. Good afternoon. Good morning, everyone. Thanks for your time today. Thanks for your attendance. PRA is really proud to partner with Stat on this series. We think it's an exciting way to meet and interact with our clients and hear the challenges of healthcare, not only from drug development, but also the healthcare delivery side. My role at PRA Health Sciences is that I help take all of our global heft, all of our global expertise and diverse geographies and help bring those to biopharma companies and find the best ways to develop their drugs. And reviewing some of Usha's works today in preparation for this discussion, I was really struck with how diverse the healthcare delivery side of healthcare is, and how important it is for us to consider the real world and everything that we do and the ways that drugs can reach patients and have both intended and unintended consequences. This is a big and challenging problem to be able to solve, and developing great drugs is only one part of it. We're grateful for all of the existing partners, client partners that are here today, and look forward to meeting others and future clients in the future. Based on this discussion today, I think all of us have a renewed and shared commitment to really consider the ways and the complexity of healthcare delivery. What is our obligation to global health, and where does clinical research come into this? Where does the drug development spectrum fit into how healthcare is delivered? And in what ways can we always be thinking about disease heterogeneity and race and ethnicity in the patients that we're interacting with? I look forward to partnering with each of you in the coming months and years to help solve these problems, to help think about the end patients that are receiving the drugs that we develop together. And thank you for your attention and attendance today. And with that, I'll pass it back to you, Rick, and the Stat team for the rest of the conversation.
Thank you very much, Brandon. Now I'd like to introduce our featured speaker for today. Please welcome my colleague, Usha Lee McFarling, Los Angeles correspondent here at Stat. Thanks for joining us, Usha.
Thanks, Rick. I'm happy to be here.
And what a year last year was as the pandemic collided with the reckoning with racism. And you ferreted out so many stories at that intersection, and stories that no one else had, no one else told. You wrote about the plight of immigrant communities, Filipino nurses, the Cherokee Nation, on and on and on. So I guess I'd like to start out by your talking about how did you identify those story targets? How did you go about coming up with these stories in the first place?
Yeah, well, thanks for the question, Rick. And first, I'd like to just say I really appreciate Brandon's remarks at the beginning, because I think, you can have the greatest drugs, or as we're seeing now, incredible vaccines. But we really have to think about from the beginning, like, what if you can't get them to the people that really need them? And I think that's what a lot of these stories got to the heart too. For me, I just feel really lucky to be based in Los Angeles. We're such a diverse city. We have not only our very large Black and Latin communities, but we have just about any ethnic group. You can see whole blocks that are just Korean, Armenian, Bengali, Thai, all of the businesses in those languages. So I think from the start, I just went to our community clinics because each of these areas have their own doctors, their own healthcare systems. And this was early on in the pandemic, and we were really focused on like healthcare workers getting sick or international travelers and screening at the airports. But these doctors early on were saying like, it's my Latino patients, it's they're taxi drivers, they work in the grocery store, they live with their grandparents, they're all packed in these houses. So I'm really worried about this community. And that was really way before the statistics started bearing that out, which they did. And I think what it showed me is that, I think early on, a lot of the stories and the statistics were about minorities or people of color. And there's, it's not just one group. They're very different groups. They all have their own challenges and stories. And so I think it's important to tell as many of those different stories as we can.
One of the most memorable for me, at least, was your Filipino nurses story. Can you talk a little about what that was, what you found, and the impact and the response you got to it?
Yeah, I'm really proud of that story. I think we were the first to tell that story, and now many, many media outlets have told it. It's, it's such an important story. And for me, it was just early on, we were seeing all those obituaries of healthcare workers. And I kept, I don't know, it hit me after a few days. I kept seeing Filipino names among the dead. And then I was seeing husband and wife both dying, often because they would both be healthcare workers, or whole families, where the child then goes, they're working at different institutions, bringing home the virus, infecting their whole family. So, it was heartbreaking. So I started looking into it, and I learned that, Filipinos are just 1% of the American population, but they're 4% of nurses. And in California, they are 20% of our nursing staff. So I thought, wow. So this all stems back to like colonial times in the 19th century when in the Philippines, the military trained nurses to take care of their soldiers. So we had these extremely well-trained, population of nurses that over the years, we have imported when we needed nursing. And it's a community with incredible pride at what they do. And these are incredible. If any of you have been in the hospital, these are incredible nurses that take care of their patients. So they call themselves PhilAMs, Filipino Americans. So I called the PhilAM Nursing Association. And literally, that's when I knew this was a huge story. They were like, our executive director's out, she has COVID, her husband died last week. And then they're like, the phone's ringing because other Filipino nurses are calling to say they have COVID, they're worried, they can't get PPE. So immediately I was like, wow, this is an important story. And it turns out, why were they getting infected at such high rates and dying? Well, I talked to a Filipino nurse who's also a professor, who's also works with the association. These nurses, they heavily populate the ICU, the most difficult nursing jobs these nurses often do. They're very often working in nursing homes, working two jobs, like at a hospital in the day, maybe a long care facility at night. They are, their whole culture is of treating patients like family. So these are the nurses that will be bathing the COVID patient, holding up the phone so their family, at their own risk, their family can see them and talk to them. And they're also a culture that doesn't speak out very much. This is changing. The head of the nurses union in California is, for the first time ever, is a Filipina American. So, but they're not willing to complain maybe. And so they weren't getting PPE, they weren't speaking out. And I think what was the hardest thing for them is, as they were suffering this toll and they and their colleagues were dying and they were so worried, and they were like, even not worried if they die, they were worried, if I die, what happens to my family and the family in the Philippines that I'm sending money to that can't survive without me? So it's deeply stressful and traumatic. And they felt like they just weren't being seen. I think all healthcare workers were heroes, but one of them said to me, I'm in the back doing the bedpan and the intubation, and it's the white nurses on TV. And it's hard to say, those white nurses are heroes too. But I think with all their pride and all their hard work, and then to be invisible was just another level of pain. And I thought about this during the Super Bowl when we had the 3 healthcare heroes introduced. And again, all nurses are heroes, but we had, I think, 2 African-American, a teacher and a veterans advocate. And the nurse in the Super Bowl hero, it was a white nurse. So again, I think this invisibility continues.
You were saying that some of these nurses sort of culturally, they don't want to be in the spotlight. So how did you win them over to talk to you? And complicating that is, how did you get them to talk to you when you couldn't interview them in person?
Yeah, it was hard. I mean, you kind of ask 10 people if they'll talk and maybe one will. I had to rely on networks. People would, if I knew them and they had friends who were Filipino nurses. The head of USC nursing here in LA is a white woman, but she's married to a Filipino physician. And so she was just very supportive of her nurses, and she put me in touch with people. So it was trying to, and when someone like the head of the Filipino American Nurses Association gets on board with a story, then they will say, please talk to this person. And it was even just challenging because a lot of them were working double shifts. They were staying in like the COVID hotels because they couldn't go home. A lot of them were afraid to speak out because people were punished in the early days. You'll remember nurses were disciplined for asking for PPE. So it really was difficult to get people to speak. And the ones that did were just, I think they were so hurt, they were so exhausted, and they really wanted people to know what was happening. They didn't think people were taking the virus seriously. I talked to a lot of people in New York and New Jersey in those early days. And so I think they thought it was maybe their duty to speak out, some of them.
Let's talk about a story that had a totally different angle, and that was the Cherokee Nation story, which was another fascinating take on something that no one else had written about until you came along. Can you talk about that piece?
Yeah, that was really interesting. So that started, I had heard that there was a Oklahoma State, which is where one of the Cherokee Nation tribes is based. Oklahoma was starting a tribally affiliated medical school. And so I was looking into that thinking, well, gosh, there is such a low percentage. I think it's less than 1% of American physicians are Native American. So is this a way to get more Native American physicians into the pipeline and improve the healthcare of those communities? But as I was learning about that, I kept hearing about, oh, well, we want to work with elders, Cherokee elders, but they've been sequestered, because of the virus. And well, of course, there's that mask mandate on the reservation. And I was, and I'm not sure if you know, but Oklahoma to this day does not have a mask mandate, but yet the tribe within Oklahoma did. And then I was hearing about contact tracing and their COVID-19 dashboard, which was very sophisticated. And this was early on. And I thought, what? So it's like, okay, this is a way better story. So I got in touch with the leaders. And again, it's difficult. I'm not Native American, I'm viewed as an outsider. There's, can be so suspicion, a lot of negative press about Native American communities, a lot of what they called poverty porn, where people just want to write about how bad things are. And so, but I did finally get an interview with the chief. So it kind of starts there, like going to the leaders and explaining what you want to do and why you care. And I think once you have their buy-in, it opens the doors to talking to other people. But I just could not believe what an incredible response they had. Just a few dozen deaths. I mean, every death's a tragedy, but compared to the similarly sized Navajo Nation had hundreds of deaths. They had veteran public health people. When federal officials, including William Barr, the Attorney General, came to the nation for some, a legal issue they had to discuss, they forced him to wear a mask. And this was like days after he'd been at that Rose Garden super spreading event. So literally I had to call them back when I learned that. I was like, are you okay? And they were like, yep, he was masked the whole time. We're no spread, no cases. They were contact tracing before the CDC even recommended it. They went and searched how they contact traced in Ebola. They were so innovative and smart and quick, and they knew they couldn't lose their elders because these are people that are keeping the Cherokee language alive and all these artistic traditions. So that story just ricocheted. I just couldn't believe the response to it. And I think partly it was so clear that you didn't need endless resources to fight COVID. You needed leadership, you needed trust in science, and maybe like a hefty dose of common sense. And these were people that, just the last thing was like, these are people that would dryly say like, yeah, we know a thing or two about, diseases coming from overseas, so they took it seriously from the beginning. And I think it was really inspiring because it turned that whole suffering native, myth on its head.
Do you know if anyone tried to learn lessons from them? Like, I would think that federal and state officials and people from other countries would line up and ask them for advice.
Yeah, you would think. I mean, it was such a fraught time because like literally they had such a good relationship with the CDC, and they'd had people from the CDC come and learn from them, and they couldn't really talk about any of that because it was so, it was such a time when the CDC was clamped and muzzled. They didn't want their CDC person taken away. So I feel like people should study them in the future. I don't know if in all the chaos they would. And it was also difficult, like Oklahoma, the governor refused to have a mask mandate. So like within the borders of the state, they were like these upstart public health revolutionaries, and their own state wasn't, and their own federal government wasn't listening to them. I don't know if that will change, in the future.
From there in LA, you've had a sort of a front row seat to how the impact of the pandemic, and it's been sort of an up and down situation. Could you take us through the arc of the pandemic as you've seen it in California?
Yeah, it's really interesting. In some ways, it brings to mind September 11th, when I was at the Los Angeles Times, and of course the planes hit the towers and it was like so terrible in New York. And I remember we were like waiting for LAX to be bombed, and then like nothing really happened. And I felt like the same, like we saw what had happened. And the spring was so interesting to me because LAX is such a huge point of, travel from people coming from China. And we had direct flights from Wuhan daily, like all through the spring, even after we knew, it was like, what? So I was just like, looking at my watch, like, okay, when's it gonna start? And, and we had the flare up in Seattle that was really detected because of their incredible surveillance there of virus and their genomic work, and San Francisco. And then we really dodged a bullet, and our cases, we were also terrified at the time, but you look back, our case rate then and positivity rate was really kind of low compared to what we've kind of grown used to. And some people think that because it wasn't so bad in the beginning, we just never were scared. We never were scared enough to take it seriously. I think our public health response has been like robust and strong and clear. But we have, they're just gatherings, you've seen probably on the national news, these big parties in the Hollywood Hills with so many people, businesses like secretly staying open, we've had like speakeasy restaurants, so it was just, the virus was just bubbling along. And then I think with the holiday travel and everyone thinks LA is so warm, we can do everything outdoors, but it gets dark at 4:30 and it gets a little bit cold. So, we moved indoors too in the winter. So I think all those things, along with not taking it as seriously as some of the East Coast cities did, led to this, explosion where our cases rose so quickly, unbelievably, exponentially, and we could hear it. I could hear the sirens. At that note, starting mid-November through February, it was like 8:39. It was like people tried to make it through the night, and then you'd hear the sirens in the like mid-morning of like people needing to go to the hospital. Sometimes ambulances were circling for like hours trying to find empty beds. I mean, it was really, really a disaster. And now we're, it's like, it feels like, was it a nightmare? Because now our cases have dropped, like a roller coaster so low. It's a relief. I'm also, we're also very worried about, reopening and what will happen. next. And we have had so much suffering in different communities, stories still not told. I think the depth of the suffering, the losses are something we're going to be dealing with for a long, long time.
I can't get out of my mind that notion of hearing these sirens. That's really powerful. Can you talk about how patients have been affected by the pandemic, and I mean also non-COVID patients, and how cancer treatments and other treatments have been affected, and who's going in to see their doctor, and who's afraid to even go get checked out?
Yeah, I think this started, I think early on people just refused to go to the doctor. And so I think we saw this in New York, we saw it in Los Angeles, like people with heart disease, people that were very sick, were just dying at home because they were so frightened. I think within a few months, they put in a lot of protections. But I was speaking with a physician this morning for another article I'm writing, and she said like she still has to sometimes spend she has to literally get on the phone to cajole patients to come in. Sometimes spend like 15 minutes and then they still won't come in. So people are still frightened. And also there's just, again, just like there's different minority communities, there's different patient communities. And I think the pandemic has affected, these different types of patients in different ways. I think what's been in some cases very sad, like in sickle cell, there were very promising clinical trials underway right at the start of the year. There was a global meeting and they were just like, this is the year. And then of course they had to shut down a lot of the trials, at least temporarily, or patients were too afraid to come in. And just getting treatment, even for people who wanted it, was very difficult. On the other hand, there's been a little bit of a silver lining, at least for people who have the technology to participate virtually in their care. I've seen, and I don't even think this story, we've reported on this, but I feel like, I don't know that people really realize the revolution in cancer clinical trials, even doing things like physical therapy remotely, which really helps like the frailest patients, elderly lung cancer patients who just can barely leave home, mailing chemotherapy drugs. This has also been true in like opioid addiction, and just really trying to like meet people where they are, let them talk to their doctor for 15 minutes by phone instead of like driving across town and parking. Mm-hmm. So I hope a lot of these things stay, and I hope that communities that, rural communities, poorer communities, I hope there's a way to boost their, digital resources so that they, again, the people that need it most can also partake in this, what I'm sure is here to stay.
Let me just tell everyone, feel free to just come forward with any questions you have at all for Usha. Let me ask you this. You made the point earlier that every community is different, and there can be stereotyping and generalizations going on. How do you approach this coverage without being careful and sort of making sweeping conclusions about a certain community or certain patients? Because some of the coverage I've seen is a little too simplistic, and this can be obviously complicated questions of science and health and so forth, but what's your approach of making sure you're scientifically correct and accurate, and not, but also authoritative, but also being confident enough to make some, to make some conclusions or offer some conclusions?
Yeah, I mean, these are really deep and important questions, and I feel like, I learn more about how to do it better with each story, but I think it starts with really listening to people, and being humble, or saying, look, I'm not Chinese, or I'm not Black, so can you explain this to me? A lot of the things are really painful. Maybe people don't want to talk about them or share outside their communities. I've been seeing a lot of things on Twitter, like not all Black vaccine hesitancy is due to Tuskegee, and Tuskegee is not the only reason, Black Americans don't trust the healthcare system. But like every, Black physician I've talked to, Tuskegee is like the first thing they mention. So yeah, I'm like, well, so maybe it's like that there's obviously differences of opinion within the community. So, I mean, I think one of the, side effects of this pandemic is just reporting by Zoom, and it's inefficient and we all get tired of it. But I've sometimes spent 2 hours with a person. I mean, they're so sick of me by the time I'm done. And then I call them later, I text them with more, but it also like, it's so much more time than I would normally spend in a non-pandemic story where I would like just be on the phone or with them very briefly for an interview because, people are busy. So I just feel like I've gotten to know people better and in a deeper way. And maybe that's helping with some of this cross-cultural communication.
Really interesting. I never would have thought that. I would think that there's a distance when you're not with them personally.
Yeah, but I think because a lot of reporting is by phone, so at least with Zoom, you're seeing people, and like sometimes you see their house, and you're talking about other things. So I literally, I mean, I'm like much closer to some of my sources than I had been in the past. They'll write me about another story I did, or they're, so that's been a benefit. It's been interesting, but I really think listening is important, and it just brings to the importance of. I'm not saying like only a person of a certain ethnic group should cover that ethnic group, but it is important that we have more diversity in our reporting staff. Like I'm so happy to be at STAT, which values these stories and values having a staff that is diverse enough to tell the stories. So that's always great because a lot of these communities, I think, feel like they're telling their stories to their community newspapers and media outlets, and increasingly, there's websites and newsletters. So how do we tell them to a larger world and stay true and, be honest and don't exploit them?
Let me go to a question from Maris Payton, who asked, can you speak to the vaccine rollout in California? The Bay Area is known to have a larger anti-vaxxer community. Has vaccine hesitancy been a struggle?
Yeah. I mean, I haven't covered this directly, but I'm keeping very close tabs on it. I think when I did my story, I did a story about why the pandemic got so bad in Los Angeles, and it helped me see that I didn't really fully understand my city. I didn't understand that we had a lot of anti-vax. I mean, a lot of people that were sort of anti-science, anti-federal government. We had people that. We're really interesting because we have like anti-vaxxers on both extreme sides. Like we have MAGA protesters who are like, no restraints, open all the businesses and no vaccines. And then we have like the really healthy granola hippie Gwyneth Paltrow attending, Malibu parents, wealthy, who don't vaccinate their kids against measles, right? So they're both so extreme. I think one source said like they actually meet again on the other side of the circle. So we have these populations. I feel like the Bay Area is doing a better job of vaccinating its vulnerable communities. I'm seeing, you can probably Google this, but I'm seeing these maps laid side by side of who's getting vaccinated, like one community, and like versus which communities are vaccinated, which have the highest rates of COVID. And it's inverse, right? So the vaccine is going to the communities that have had almost very little spread of the virus. Mm-hmm. And that's very, upsetting. I think LA has such extremes of poverty and wealth. I think this is a national trend, and we just see it writ large here.
Let me go to another question from Charlene Frizera. Did the Cherokee Nation have any information about long hauler symptoms, post-hospitalization, or those that were not hospitalized?
That's a really good question. And I don't know. I know that they were using convalescent plasma. They were using, every tool at their disposal. And they were just so, we've had these stories about hospitals that are sitting there with the plasma, but not using it, or they're not getting it to people when it's in time, when it's effective. So I feel like they were just so efficient in their care and their treatment, and quickly getting people into hospital and having enough PPE. So like there could be lots of employees taking care of everyone. But that's a good question. It's something I'll look into.
How did we're all personally handling this pandemic in different ways, and we all have know people who are affected more directly. But reporting on these people's lives so closely, and the deaths and the illness and the devastation, how has and you've covered a lot of stories over the years, but has this been different for you, and how have you coped personally in covering this?
Yeah, I actually was sent to SARS by the LA Times, and I was like a young, and I just jumped in. I just had no fear. I was younger, and so I think about that because now I think because I spoke to so many people from the ERs of New York and the ICUs early on, I knew. I was like, whoa, this is terrible. Like, this is terrible. And you can be young and you can be healthy and you can still get very sick. So my poor family, has been like, so I've been very cautious and conservative and careful. And I follow like the public health rules to the letter. And I try, but they've never said like, you can't go outside, you can't go on a walk. So I've just been trying to moderate that. I just try to get outside. I try to exercise. I play like games with friends on Zoom, so I do a lot of that, and that's been helpful because it's been a long time, but I really miss skiing. That's something I think I got a few trips in before the pandemic really hit. I actually thought I got COVID at Mammoth because I sat with people from Switzerland, but who knows? And then now, I haven't gone and probably will not go this spring because of the high rates of virus that remain in California.
Right. A question from Beth Childs. Could you please talk about mental health and how that relates to changing social norms, both across different communities and also more generally? As such social beings, do you think we will ever fully recover from shifts in society, like more reliance on technology at the expense of in-person interactions, as well as growing political bipolarization brought on by the pandemic? There's a lot of big, weighty issues there, but answer that however you please.
Yeah, I mean, those are really deep and important questions. And I do feel strongly that issues of mental health have been on the back burner. We've been just focused on like sanitation and ventilation. And, I think it's come up mainly with reopening schools and like, okay, there's a risk of COVID, but there's a risk of not being in school. And these kids are falling off the radar. I think it's also interesting that some people seem to have thrived. I think introverts are like, wow, I don't have to go to every party, or wow, I can like stay home and it's okay. So I think there's a whole range of things. I think virtual therapy, if that stays, I think will help, whereas people can sort of get help in like really efficient and lower cost ways. But I think the trauma of this is, again, it's like untold. I think it's going to take decades to sort everything out. And I think, again, every person's story is like unique. There's so much grief, there's people that still set a place at the table for people they've lost. I see pictures of that. It just breaks my heart. There's so much, like, I just think about young people, like maybe in their first job and they can't like socialize, or, kids who have lost, not been able to go to college and they're still stuck in their parents, house, and high school kids who didn't get to graduate, and grandparents who don't see that, it's just like, there's so much sorrow and loss, and we're not even beginning to deal with that as a nation, as a society.
Yeah, I think you're right. People have asked me sort of what stats, how will stats focus shift post-pandemic? And my response is, what do you mean post-pandemic? There won't be a switch where this just ends. This is going to be with us in some form, dealing with the repercussions for the rest of our lives. I mean, the world is not going to be the same anymore.
I think you're right.
What do you, when you think about these overlooked communities and you think about this year, what are some of the things you're looking at or worried about or that you have your eye on without giving away all your story ideas?
Yeah, my top secret story dropping in a few days. Well, I mean, I feel like this giant, okay, so I'm in LA of the city with the giant spotlights, or used to be when we had movie previews. I feel like this pandemic, I think I put it in a tweet. It's kind of been an MRI of our institutions, of ourselves. You look at some universities that have just done a terrible job taking care of their students. Some have been amazing. Some hospital systems, some county public health systems, likewise, amazing, terrible. So it's really shown a light on problems that have already existed, and the death, the terrible deaths of Black men under police custody, those have as well. And I think my work has sort of been at this intersection where, we're looking really closely and hopefully honestly at these issues in a way that's so long overdue. But I worry that, when the pandemic, okay, we won't say ends based on your last comment, but when it eases, I worry that we're gonna just go like in such a race to get back to life and our cruises and our, clinical trials and our important work that is all really important and people need, but that we're just going to kind of forget about what a crisis this has been and how unfair so many things are and how vulnerable and overlooked so many communities are, and that the wealth is not shared, the knowledge is not shared, the medical treatments are not shared. And so I'll keep working, I'll keep reminding everyone as they read my stories, but I hope as a society we keep some of the urgency, even as the crisis abates.
When you said something about not forgetting, I think it's always very important to think back to lessons learned from other crises. And one story that I have to mention is the story you wrote talking to sex workers and how they handled themselves during the AIDS crisis and what lessons there were that could apply today to the pandemic. Can you talk about that for a second?
Yeah, it just struck me that, okay, again, I'm in the city with this big industry of creating, porn movies, and they've had to deal with HIV and other STDs that can be very dangerous if left untreated. And they have this like high tech sort of system that can't be forged with an app, with doctors, running tests. And they've really been able to continue their work without having outbreaks of HIV on sets. It's not perfect, but it just seemed, because when we were thinking early on, like, how will when we thought we'd be away from our offices for a few weeks. Do you remember those days? Right. So it's like, what can we do to go back to work and not infect each other? And they seem to have this model system that even top public health experts were like, yeah, this is great. Like I could see something like this. And it was a little bit like, I think the Filipino nurses, they were like, no one comes to them. No one asks their advice. They're so stigmatized. They're so maligned. It was like people didn't want to have anything to do with them, even though they'd maybe done like 75% of the work to develop a validating testing system to ensure safety in the workplace that, like, I think meat packing plants could have used, Amazon warehouses, we could have saved lives. But again, it's like, there's so many communities that just are not, that people refuse to see or listen to or learn from.
I think that's a thread in your story from the porn actors to the Cherokee Nation to their lessons everywhere around us of how you can handle crises, of public health crises. Let me go to just one last question from the audience, from Michael Durand. And he asked, if you were a public health educator, which you're not, but you kind of are as a journalist, but not really, what communication strategies would you use to convince vaccination deniers that they should get vaccinated and have their family members vaccinated?
I just think the messaging has to be like bold and direct and strong. I think because of patient privacy and like the chaos, like very few journalists were let into ICUs and photographers. And you should just have a camera rolling in an ICU, show people intubated, show them, show the nurses like cleaning up the room after. And it's so sad. It's so scary. It's so terrifying. But someone was saying there's no iconic image of the pandemic, and I kind of disagree, because I think the exhausted nurse with the lines from the N95 mask, I think that's the iconic image. But we weren't allowed to see the death. We weren't. As reporters, I saw it. I heard it. I talked to people. I think more people need to know what is actually happening, how people are expiring, how terrible it is, how sad it is.
I think we get inured to the numbers every day when we don't realize that it's hard to absorb and to the numbers. And
Yeah.
I think the more we can be reminded of the devastation and the lives upended, the better. With that, I think it's time to wrap things up. I want to thank you, Usha, again for joining me, and to our audience for tuning in. Usha, I hope I'll pray for the day when you can get back to your skiing and your somewhat of a semblance of a normal life. I have a feeling that may not be for a while. Again, we'll be hosting our Stat Plus conversations on Tuesdays around 1 p.m. Eastern Time each week. Be sure to sign up for our next chat on Tuesday, March 9th, where my colleagues Gideon Gill, Olivia Goldhill, and Bethany Mollenkoff will discuss an on-the-ground look at racial disparities in vaccine distribution. We hope